"I have a dream," stated Martin Luther King in 1963 in his powerful speech demanding a guaranteed right to life, liberty and the pursuit of happiness for all, and to move from injustice to the sunlit path of racial justice. For those of us who work across environmental sustainability and healthcare, there is a related dream. We dream for the right to environmental guarantees, such as the right to breathe clean air or drink clean water for all. Environmental justice directly links to health justice and highlights how our health is shaped by the wider social, economic and environmental conditions in which humanity lives. We have a dream that all in the global north and south, east and west can work together to tackle some of the causes of ill health that are rooted in social and environmental conditions. That collectively we can tackle the climate and ecological crisis, that we can reduce greenhouse gas emissions and vitally protect the living world upon which we depend. These are essential to avert the very real and present danger of climate and ecological collapse. The inspirational Kate Raworth has shown us there is a way this can be achieved. She designed this donut of planetary and societal boundaries. This is a framework which defines the very harmful processes which are occurring on the Earth, such as acidifying the oceans, polluting the air and destroying living plants and animals, and the social foundation within which humanity can continue to develop and thrive. The diagram highlights there is a sweet spot, the donut, where we collectively ensure no one falls short of the essentials, from sufficient food and clean water to housing and education, and from equality to healthcare. However, we are already breaching the ecological ceiling in places and exceeding our planetary boundaries. What would an environmentally sustainable future mean to primary care? The Cambridge Dictionary defines sustainability as the quality of being able to continue over a long period of time. For mankind to continue, we must live within our planet's means. To continue to live, thrive and survive as a species, we need to take a step back from breaching the planetary boundaries. For example, we cannot continue to take more resources from the living world than it can replace. We cannot deplete the ozone layer, acidify the oceans, or continue to pollute the air, water and soil. Collectively, we are moving towards an irreversible collapse. There are interactions across all areas of the natural world, whether in the soil beneath our feet or within the blue waters of the oceans, and these myriad of codependencies are essential to our survival. We ignore the evolutionary processes which have occurred over the millennia to produce a balanced, natural living world at our peril. 4.5 billion years ago, when the Earth was being formed, the average temperature on the planet was around 80 degrees centigrade. About 600 million years ago, in the last ice age called the Cryogean period, also known as Snowball Earth, during this time ice covered large swathes of the planet, with glaciers blanketing huge expanses of the northern hemisphere and ice present in the equatorial regions. NASA calculated average global temperatures were closer to -10 degrees C. The planet has been through far worse, but we have not. This emphasises it is not the planet which is in danger, it is us. We as humans are in danger from the climate crisis and ecological collapse. It is recognised that climate change poses the most profound threat to the health of the nations. There are many aspects of environmental harm that are currently occurring, but the one which contains every single other issue is climate change. Sarah Birch, one of the lead authors on the latest Intergovernmental Planet on Climate Change, said we cannot reach our broader sustainability goals of vibrant nature, clean water, no poverty and healthy communities if we don't address climate change. We have our dream to not cross the planetary boundaries and tackle climate change while meeting the needs of fellow man, and for us to provide high quality primary health care. To our dream, if we had a date, we create a goal. In October 2020, the NHS was the first healthcare system in the world to announce a net zero ambition, and crucially to set a date by which this was to be achieved, 2045. That is for all NHS greenhouse gas emissions, both those under the direct control and those within its influence in the extended supply chain, to reach as close to zero as possible. The Greener NHS has a plan, and I would recommend this report called Delivering a Net Zero National Health Service. The plan goes into great detail for different emissions from different sources and the actions that can be taken and the expected impact from those actions. However, I would argue that the focus is towards secondary care. So what about us? What about primary care? Can we have a similar goal, or could we be even more ambitious? Our goal could be written as how to provide and deliver high quality primary care services without harming the natural world around us or contributing to the climate crisis by 2040 or 2035 or sooner. When setting our goal, we need to listen to the science. We have practiced evidence-based medicine for decades. We can do the same for addressing our contribution to the climate crisis. When setting our goal, the Science Based Target Initiative has many practical resources to help. For example, they offer guidance on near-term targets and longer-term goals. An example of a short-term target could be to reduce all fossil fuel energy use in the practice and across the whole of the primary healthcare to zero by 2025 or 2030 at the latest. That is no methane gas used on any primary care site or facility, and all electricity from only renewable energy sources. Longer-term goals can set targets to reduce all emissions from travel, medicine and all suppliers by a predetermined date. All unabated emissions must be neutralised. For the whole NHS, this is by 2045. We in primary care can be more ambitious. We benefit from shorter management structures, smaller, more versatile teams, and see quick results from our actions and interventions. We are fleet of foot. If we break our goal into steps, we create a plan. Key steps in a primary care and family medicine plan could include that we need to understand the emissions for which we in primary care are responsible. We need a deadline, a time or date to complete it by. We need realistic and achievable but ambitious interim milestones. We need to work with all staff, patients, families and suppliers to help implement the actions. We need to create leaders and enthuse their followers. Primary care has taken quite a battering over the last 2 years of managing COVID, and the long-term effects of the infection are only now starting to be identified. We will be working harder than ever for some considerable time to come. How can we undertake more work, a plan of this size of magnitude in our current state? Personally, I see this as not doing more work, just doing what we do in a different way. Practitioner health and the effect of overwork and burnout is vital to address. We still travel to our practices, we still heat our buildings, we still deliver high quality healthcare, and we can do it all with less harm to the environment. The skills and knowledge to identify our emission hotspots from across primary care and within our practices are already known. In the UK, the emission hotspots for general practice are split roughly 60% clinical emissions, 40% non-clinical emissions. Clinical emissions are those from prescribing medication and the propellant gases in inhalers. Non-clinical emissions are those from running our practices. The hotspots of the latter can be divided into 4 key areas: energy from gas and electricity used, travel of staff and patients, business services to run our practices such as financial services, IT, water, waste, insurance, etc., and procurement of supplies of medical and office goods, equipment and consumables. If practices had their own information, they could start constructing their own practice plan. What sort of actions could we undertake next week, next month, or in the rest of this year? What actions could you and I take over the next few years? What could I do in my practice, for my practice, and with my patients? I reiterate, although this sounds like hard or at least extra work, for me this is absolutely not about doing extra. It's about doing things differently. For example, we already have continuous professional development to learn and keep up to date with how we can best aid and assist our patients, to learn new knowledge and skills. An action can be that before the end of this year, our practice staff have signed up to and completed a carbon literacy training course. Understanding the science of the climate crisis, the impacts on our staff and the delivery of our services, the effect on our patients and their health, and learning the skills needed to take meaningful action is not adding to our workload, but learning something different, something new to help our patients. When staff are on board, it is a small step for a practice to initiate a green community. There isn't just one green champion in a practice, but many, each with their own area, their own enthusiasm. For staff who are interested in single-use plastics or recycling or energy use or biking to work, let them lead that area. As GPs, partners and practice management staff, sometimes all we need to do is to give others in our team permission to enable them to achieve great things with their passions. Our understanding of our emissions is enhanced if we gather the data and the numbers. We need these to make the right choices and the best decisions for our patients and the environment, and it makes action planning much easier. There is a free-to-use GP non-clinical carbon calculator available. This identifies your hotspots based on your data. An action for this time next week is to work with the practice manager to complete your own practice carbon footprint. With this data, a plan can be formed and the actions initiated. This is based on some work from Salford and shows the average proportion of each non-clinical hotspot across practices. Energy is expensive and the biggest emissions hotspot. If your energy use is similar to the national UK average, it will be between 35 and 40% of your practice's non-clinical emissions. One place to start is to understand your energy use better. A first action is to examine the practice energy bills. How much did you use in the last 12 months? How much was gas and how much electricity? Who was the energy company? And what proportion of renewable energy did they provide you with? A priority action is to start reducing the amount of energy used. The lowest carbon and lowest cost kilowatt hour of electricity is that which is not used. I don't know how many of you have walked around your practice at the end of the day when most of the practice staff have left and you've seen how many monitors, fax machines, computers, photocopies, etc. have been left on or left on standby. One practice recognised this and implemented an action. An electricity responsibility plan gave the responsibility for the electricity used by that office or consulting room to the person who last used it. The lights were switched off, the computers, monitors and printers turned off at the plug each evening when the staff went home. The practice saved over £1,000 in a year through their cumulative action. In the UK, that's around 1/4 of a tonne of greenhouse gas emissions reduced by one practice doing one simple action. Imagine if all practices did the same. Heat loss from leaky buildings is a source of frustration, financial loss in energy bills and environmental harm. Staff and patients don't like being in cold, inefficient buildings with drafts in cold weather. Investing in the fabric of the building and reducing heat loss helps the working environment and subsequently staff morale, as well as reducing bills and emissions. In the winter, if you can feel cold air coming in, it means somewhere heated air is leaving the building. Installing a smart meter can give a practice real control over understanding their energy use. Look to see what was used at 3 AM on a weekday, on a normal Sunday or on Christmas Day can really help to shine a light on what power is being used and what could be switched off or reduced. An action for next week. Check your practice energy use and what equipment is responsible for the majority of it. A longer-term action is setting a practice energy plan to reduce the energy used by 10 or 20% in the next year, to only replacing the equipment with the most long-lasting, energy-efficient alternative that there is, and to start preparing your buildings for non-fossil fuel heating through improving the building fabric. Finally, when your energy contract comes to an end, the practice will spend some time looking for the best deal available. Focusing on reducing the practice carbon emissions means the best deal for the practice and the planet can be found simultaneously. Travel is another large proportion of non-clinical emissions for a practice. The exact proportion depends on size and location of the practice, access to walking or cycling routes, levels of deprivation and inequality, car ownership levels and many other factors. An action is to carry out a staff travel survey. Questions can be asked not only about current methods and modes of travel to and from work, but also their aspiration for travel. Imagine a warm sunny day with no other commitments such as dropping a child at school. How would you like to travel to work? When this question is asked, most people would rather walk in the sunshine with friends or cycle rather than drive. Information can be essential to identifying and then overcoming the barriers to travelling more actively. Is it a lack of facilities at work, lack of information, other commitments, start and finish times of shifts? Explore these across your staff and the actions needed are often revealed. One such survey revealed that several members of staff who were friends outside of work and lived close by each other all travelled separately to work. When asked why, it was because their shift patterns, their start and finish times didn't coincide. It was a relatively simple action for the practice team to align the shifts and suddenly the friends travelled together. They took 3 of the 4 vehicles off the road, quartered their fuel costs and improved staff morale as they could see each other far more often. For patients, a survey also helps. An action can be simply to ask the question about travel intentions. There have been surveys, for example in the Humber region, which showed that patients currently using a car to attend their GP appointments, 25% would like a more active form of travel. These are the open doors we can be pushing on as the ambition is already there. People are much more likely to become active if advised by the doctor or nurse. Sometimes we can just water the seed that the patient already has by bringing this up as part of the consultation and advice that we provide. We sometimes forget the positive influence we have on others. We can lead by example. The staff who walk understand how to overcome the barriers to walking. Our cycling staff understand the pros and cons of being on a bike. We can use their knowledge to help spread the word and help others. Understanding the barriers to more active travel for our patients can be a very worthwhile quality improvement activity. And specific actions, better signposting, bike storage, maps on the practice website, then follow. Ask, how can I travel more actively? But don't feel guilty if sometimes you need to use a car. There are many more actions we can take to improve our use of goods, for example through better stock management and control, meaning nothing is wasted, or adopting a circular economy approach where everything is reused or recycled, or asking our suppliers of services to our practices for their decarbonisation plans. For clinical emissions, we already know in detail the emissions from the propellants in inhalers. There are great resources available, from Greener Practice and their high-quality, low-carbon asthma toolkit, to greeninhaler.org, to the inhaler emissions table recently published in MIMS. An action for the next week is to visit the Greener Practice website and see their asthma toolkit for yourself. This is a sustainable quality improvement project for you and your practice to improve the outcomes for your patients and for the natural world. We already use quality improvement techniques to improve the care provided to our patients. We can go a step further. The Centre for Sustainable Healthcare has an excellent course on sustainable quality improvement. Visit susqi.org for more information. For others, air pollution can be a driver for change. There are some fantastic resources to help clinicians to become clean air champions at cleanairhub.org.uk, including how to bring up the importance of good air quality with patients and use it for changing behaviour. We can be involved in changing care pathways, so we develop them with planetary health as well as patient health in mind. The knowledge of the emissions from the rest of medication we prescribe is not yet known to such a level of detail, but this robust data is coming. I am optimistic it will give us the tools we need to combine what medication is best for the patient, what is best financially for the health system, and what is least harmful to the natural world. So what actions for the next month, the next 6 months, or for the next few years? Each practice is different with different staff and different starting points, but we are all on the same journey, all trying to make the world a better place. Some of the actions we can take are shown on screen. In summary, the tools needed for low-carbon, high-quality healthcare future aren't waiting to be discovered by billionaires. They already exist and are waiting to be discovered and implemented by us and our colleagues. No one person can do everything, but every person can do something. Together we really can make a difference, and the actions each of us can take benefit our patients, our practice staff, our practices, the wider population as well as the living planet. I will leave you with a quote from Maya Angelou that reminds me of what we already know and drives us on. Do the best you can until you know better. Then when you know better, do better.